Hello, everybody. This is Stacey Gulick from Garfunkel Wild, and I am here to present Dr. Marc Koch, who is going to talk to us a little bit about all of the problems and the solutions, perhaps, that you may be facing in regarding to recruiting or having enough anesthesiologists present to run your ASCs. I'm super excited about this presentation. I've been practicing with Dr. Koch, and he has some crazy interesting data I think everybody is really going to enjoy. Dr. Koch is not just an anesthesiologist. He has a very storied background, which is very interesting both at the administrative and clinical level. He has published in a number of articles in places like New York Times, Money Magazine, Crane's Health Pulse. He's been a surveyor for AAA-SF and I'm sorry, AAA-HC and Quad A. So his knowledge of this area is really impressive. I'm not going to read through his whole biography, but you will see that he is certainly a very experienced doctor and administrative leader in regard to this field. So with that, I turn it over to Dr. Koch.
Thank you, Stacey, and thanks to you and the Garfunkel team. We've known Garfunkel for the better part of a quarter century and have been so thankful and blessed to have the chance to avail ourselves of their wisdom. And special thank you for giving me the opportunity to speak with you here today. So just briefly about myself, I'm not going to spend much talking about myself. That's just who I am. I got my anesthesiologist training at Yale, got my MBA in finance at Fordham, finished my master's in science in perioperative medicine at UCL London, and for the last quarter century have been the president and CEO for Somnia. And we provide anesthesia services to office-based surgical facilities, surgery centers, and hospitals across the United States. We began and still serve the Metro New York area, but right now it's approximately 15 additional states. We have over 1,000 clinicians. My professional interest is perioperative medicine and population health and re-engineering of perioperative care. And in my career, I've summed it up for Stacey before we came on, and I've spoken with, met with, and helped, I hope, over 1,800 hospitals in my career. So let's jump right into it. So how does the demand look? Because we're going to be talking here about supply and demand and how this is going to impact compensation and other operational features that you're going to be facing. And if you take a look at ads for anesthesiologists, ads for CRNAs, and you use that as a proxy for demand, what you'll see is that it is off the charts. We are officially in a state of hyper-escalation. The demand is logarithmic. And, this actually started before COVID. So as you could see here with the first red line, the demand was starting to increase, all the way back to 16. It was ebbing up. And that was true to both physician anesthesiologists and CRNAs. After COVID, it just went nuts and things really began to fly off the charts. And we're going to go into that into more detail. But if you examine the slope of demand and you look at that pre and post COVID, there is a big change. And the change is remarkable with regard to hyper-escalation of demand. So if we examine the historical and prospective workforce for nurse anesthetists, we start to see some pretty interesting patterns. If you take a look at the number of students coming into school to become CRNAs in 2020, there were about 3,360. If you take a look at the number of CRNAs that will be coming into school, that will be 3,962. If you subtract the two, there'll be about 602 CRNAs coming into the profession in 2030, more than were coming in 2020. And these numbers are approximate. But again, there'll be about 600 additional CRNAs coming into the workforce that then were coming in 2020 by the time we hit 2030. I want you to put a pin in that number. Compensation. Well, in 2020, their compensation was about 190,000. By 2021, it was 203, 2022, 225, and by 2023, $248,000. Now, that's average, doesn't take into account regional differences. It does also include, certain insurances and benefits and such. So if you take a look at what that means going forward, if you take a look at the 324,000 in 2020 and you project out where we would have expected to be in 2023, it's 383,100. And I got some news for you. That's about what we're paying now. Can't tell you exactly how much because I'd be in trouble, but I can tell you that in broad strokes, that's, give or take, whatever, that's about what a generic practice hiring an average CRNA is going to be facing. And again, that's total compensation benefits there. Now, if you project that out to 2030, that's over $520,000 a year by 2030. So simple math, simple statistics. Let's take a look at anesthesiologists. Okay, in 2020, right, there were approximately 167 programs, and then in 2030, we're expecting there to be 225 programs. If you subtract 225 from 167, that's 42 programs. And I'm sorry, there's a typo there. But 42 new programs. Now, this doesn't include any attrition. It doesn't include programs that are going to shutter. This is just assuming, basically, if things continue as they are, based on historical data, we'll expect there to be about 42 new programs in 2030. If you take a look about what that means in terms of residents, right, and you take a look about new residents entering the field, we expect there to be about 8,000 new residents entering the field by 2030. There were 6,795 new residents entering the field in 2020. So if you do the math, each year, year over year, on average, you're going to be adding, about 1,400 additional residents divided by 10 years is you're adding about, on average, about 260, 150 to 250 new residents a year. So, that's sort of what you're dealing with. So again, 2030, 8,000 residents coming out a year, 2020, 6,800 residents coming out a year. The difference between that is about 1,445 residents per year entering the field in addition to baseline. And that works out to be about 145 new residents a year. So again, if we combine that information, as I mentioned, by 2030, incrementally from where we were in 2020, we'll have about 600 additional CRNAs entering the field on a year-over-year basis. And we'll have about 1,450 additional MDs entering the field on a year-over-year basis. That means every year in 2030, every year, that year in particular, we're going to be at a rate of adding about 2,000 new clinicians into the space each year. That'll be the rate in 2030. This does not include attrition. So we have not included people that will be leaving the field. So this is a very conservative number. It might be actually much worse than this. Now, we've talked about supply. And we've talked about what we think will be happening over the 10-year period, 2020 to 2030. What do we expect to be happening in terms of demand with regard to operating rooms that need to be covered by virtue of more surgery centers opening up? And by taking a look at the data that we obtained from the from the professional organizations, we determined that between 2020, we had about 18,739 surgery centers, and that went up to 24,000, predicted 260 by 2030. So between 2020 and 2030, we're expected to add about 5,500 new surgery centers. Well, surgery centers don't have just one operating room. They have multiple operating rooms. So if you take a weighted average of the average surgery center, it works out to be about 2.81 operating rooms per surgery center. If you then take that 2.81 and you multiply it times the increase in surgery centers, you're adding about an additional 15,500 operating rooms. Again, it's math. We're adding about 5,000 new surgery centers. Each of them have about 3 operating rooms. The math works out to be about 15,500 new operating rooms. And this shows the math again. Okay, this doesn't include surgery centers that could be shutting down or consolidating, what have you. Okay, doesn't also include some other things that we'll talk about in a second. So again, to bring all of these points home, from 2020 to 2030, okay, you're going to see in 2030, right, we'll be adding an additional 2,000 clinicians into the space, more than we were in 2020. 2,000, approximately, assuming nothing else changes in that interval. Between 2020 and 2030, we're going to see an additional 15,000 operating rooms that need to be staffed. So you tell me, how are 2,000 additional providers going to be staffing 15,000 additional operating rooms between 2020 and 2030? And this is what keeps me up at night. This is what worries me. What worries me even more, this doesn't include attrition. Doesn't bake in how many people are going to be leaving the profession over that period of time. And anesthesiologists are getting older. The average age of an anesthesiologist in New Mexico is 58 years old. We're getting older as a specialty. So the numbers in the data that I showed you over predicts the number of people that'll be in the space in the field, in my opinion, at least. It doesn't include other sinks to demand that pull away providers. So maybe there's more office-based facilities. Maybe there's more HOPDs. Maybe they start to build more hospitals, right? All of these could potentially worsen demand above and beyond what we showed in just the ambulatory surgery center market. So again, this is what keeps me up at night. I see this not being good today, not being good tomorrow, and not getting better for at least the next 10 years. So what do we do? Right? You know, I really hate it when somebody gives me a problem and there's no solutions, because what do you do with that? Right? So there are some solutions you could keep in mind and you could try. Right? One of the things you could do is you could take a look at contracting your footprint of coverage. We're going to talk about that in a little bit. Number 2, if you're a hospital or you're affiliated with a hospital, you could take a look at doing some anesthesiology fellowships. They have new fellowships called NSTs. Those NSTs permit hospital-based residency programs to bring over J1 visa holders as fellows, and basically, increasing the workforce through J1 clinicians that come over. There are anesthesia assistants, a new kind of provider in addition to anesthesiologists and nurse anesthetists that could provide care. They have to do it under an anesthesiologist, but they could still do it. and alternative anesthesia providers. So yeah, we've heard about anesthesiologists and CRNAs, but could we use specially trained nurses? Could we use nurse practitioners who are specially educated or informed and trained? What about PAs? And how about other physicians that are qualified to provide sedation? Are those potential opportunities? I'm not here to say whether they are or they aren't. I'm only telling you what I've been hearing, seeing, and listening and talking about. This is a little bit about utilization. Most of you on the phone know this like the back of your hand. If you take a look at how many minutes of anesthesia are being provided in a typical workday in an operating room, that's your anesthesia utilization. If there's a lot of downtime, if there's early closures of operating rooms, late starts, all of that could lead to poor utilization. If you start to tighten up utilization, you start to have the numbers go from the 30s and 40s to the 50s, up to the 50s and 60s, maybe even 70 or 80. Now, all of a sudden, you're condensing the surgery into a fewer number of rooms. As you improve that utilization and you have a fewer number of rooms to be covered, then you need fewer anesthesia personnel. Fewer personnel means less demand pressure for you as a surgery center. This is an example how we use that using statistical models. We take a look at a current footprint. We calculate what the utilization is on a per OR basis. We then project out and see what that utilization would be if we reduce the number of operating rooms. And as you could see here, the utilization here is in the 30s and 40s, maybe a few 50s. But as you could see, by reducing the number of operating rooms by 2 or 3 here, we were able to get the utilization up into the 50s and higher on some of those times. Now, this is a hospital, but the same principles hold true in a surgery center. And we do these same calculations for a surgery center as well, right? But as you could see here, generally you're going from 30s to 50s, right? And, you're able to reduce the number of operating rooms. Now, as a general rule, you don't want your utilization to be so high where you can't squeeze in an extra case here and there. But on the same note, you don't want it to be so low where you now have to run more rooms than you otherwise would have to. So again, we try to tell facilities, try to aim for utilization somewhere between 65 and 85. If you do that, you're not going to be so crunched that you won't be able to squeeze in a case, but you might be able to reduce the number of rooms. By improving or increasing utilization, you always have to weigh that out, because on the other end of that change, you have anesthesiologists and nursing teams that are working harder, and you have surgeons that might say it's harder for me to get my cases in if I have add-ons. So those are things to just bear in mind. So again, ways that you would operationalize improved utilization. You could just reduce the number of rooms. You could condense blocks. You could do that, of course. That's easy. You could also take on a more sophisticated approach where you maybe develop a perioperative medicine center where you evaluate the patients preoperatively and have that center schedule the patients into the surgeon's blocks. In that way, you provide a mechanism where the patients are risk stratified, optimized. Maybe they have their insurance checked and they're scheduled into the surgeon's block. So they show up, they have their whole lineup ready to go, right? It's a tactical or operational approach to the strategy of reducing downtime or improving utilization. Again, we talked about alternative providers, right? And I'm not saying you should do that. I'm just saying that's what many facilities, many locations are looking at. If not today, they certainly are going to be looking at going forward as this situation deteriorates. Again, we haven't had a problem as an organization providing coverage. Granted, we've been doing it for 25 years. We have 1,000 providers. But again, we bring certain more complex, sophisticated approaches to this problem that help many facilities, surgery centers, office space, and hospitals look at more sophisticated approaches, and in doing so, limit the hardship that they have or and we'll be facing with regard to shortages. Stacey, I hope I covered the material that you've asked me to, and I hope I've given you and the attendees some things to think about.
I mean, this is some really scary stuff. Like, we're going to have a whole lot more operating rooms and not a whole lot more providers. So this is tremendously interesting, and some of these strategies really room for thought. But I'm kind of curious, how did we get here?
Well, couple things. One, you had aging baby boomers. So these baby boomers needed more surgery. More surgery means more operating rooms. More operating rooms means more surgery centers. They were a lot of the demand was a consequence of simply needing more surgery. And that was a consequence of the macro issues in the United States with these aging baby boomers needing more procedures. Then, from a demand point of view, how we got here is a lot of the market was being propped up by late and end career anesthesiologists and to a lesser extent CRNAs. So if you remember my graph where I showed you that a lot of these shortages were percolating in the late 2020 teens, 2016, 17, 18, it started then because that's when we started to see the baby boomers needing more surgery. And there weren't enough anesthesiologists and CRNAs to keep pace with the expansion in operating rooms at both the hospital and surgery center levels. Then what happened is COVID hit. And those late and end career providers that were in the market providing care, they dropped out. Clinicians in their late 60s, early 70s, even late 70s, early 80s, they said, I don't need it anymore. So what happened is we had an acute void in the supply. And that's why we've seen hyper-escalation.
Interesting. So then where does this end up? I mean, do we not be able to perform surgery? Like, what do we do?
Yeah, it's a tough. I do a lot of thinking about that. I think you could take a look at where the natural progression of this will be, and you could look at that generically and in a sector by sector basis. So what's going to happen in the office-based market, the ASC market, and the hospital market? And I think, what could happen in any three of those markets are some of the things I talked about. You could have improved utilization, which will, on a per facility basis, will help reduce demand, right? And you could start to use, alternative providers. Maybe it's not an anesthesiologist. Maybe it's a CRNA. Maybe it's an AA, depending upon where they're located. Maybe it's alternative providers giving sedation. And those things will prevail irrespective of what segment you're in. Now, if you take a look at the surgery center market, a lot of office-based surgical facilities and a lot of surgery centers, if the anesthesia was insourced, right, and it was vertically integrated into the revenue of that surgery center, let's put aside what that means from a compliance point of view, not going there. But if they did it, right, most of those facilities that vertically integrated the anesthesia services, they're gonna have problems because they weren't necessarily as overly sophisticated in their contracting with payers, right? And they're going to be facing a hyper escalation in compensation that is going to be so huge that I can't see how those are going to make sense for them anymore. I think you're going to start to see a lot of facilities that integrated the anesthesia service deintegrate it under the premise that, you know what, I don't think I need to optimize my revenue through better contracts, better revenue cycle management. Let somebody else deal with it. And I do think that'll buy some office-based facilities and surgery centers time. But at the end of the day, what we're looking at in terms of compensation, right? CRNAs making over $500,000, anesthesiologists, perhaps making $750, $850 over the next 10 years. Even spinning off the anesthesia and deintegrating it, it's only going to buy you a little time. And I think that, ambulatory surgery centers And office-based facilities, they're going to probably have to get used to funding it, right? And they're going to probably have to say, I've spun it off, but there's not enough revenue there to pay for anesthesiologists and CRNAs. So what's going to happen is whoever they spin it off, whoever starts to take it over is going to be knocking on their door and saying, it's cash flow negative. How can I do this? So I think surgery centers and office-based facilities are, one, going to have to spin it off or deintegrate it. Number two, they're going to have to start paying for it to augment intrinsic collections. And I view that as a two-phase process, probably deintegration, spinning it off comes first. Maybe that buys a little bit of time. And then number two, after that, I think we'll start to see them having to subsidize it and pay a stipend. Now, one thing to bear, in mind as you do that is this is a very big change to where, we were 10 years ago. So I think, it's just going to take a lot of getting used to about where it goes. And also to bear in mind that the No Surprise Billing Act is going to limit the ability to let the payers come in like a knight in shining armor and start to pay more money for the service. They're just not going to do it. RVU rates are not going up; they're going down because the No Surprise Billing Act. You got to go a network, and then the really good contracts they're coming in to renegotiate it to their lower contracts. So I don't see the payers as being a potential rescue here. And what I said before in terms of the two things that I think we're going to see happen, I think are going to happen irrespective of what happens with payers, and the No Surprise Billing Act is going to probably make it even worse.
So I have many additional questions, because what I'm hearing from you is we have to change operations, we have to look at money differently, we have to embrace the concept of other than anesthesiologists staffing our ASCs. But unfortunately, we are definitely out of time. So I know you're joining us for our Q&A session, and hopefully everybody participating today will have some additional questions they can ask you at that time, and I might sneak some in too. But I really, really appreciate this. It was tremendously interesting and really heightens the awareness of a significant crisis that we're facing. So we really appreciate you pointing this out to us, as well as giving us some leads as to how we can fix this problem. Thank you so much.
Thank you very much, Stacey, and thank you to the attendees for listening to my talk today.